And we're live in 5,
4,
3,
2,
1.
Good morning, everyone. My name is Clifford Pierre. I'm a neurosurgery fellow here at the Swedish Neuroscience Institute, and I'd like to take a moment to welcome you all to our Cerebrovascular Question and Answer Symposium hosted by the Seattle Science Foundation. It is my distinct pleasure to have with us and introduce Dr. Johanna Fifi, who's a professor of neurology, neurosurgery, and radiology at the Icahn School of Medicine at Mount Sinai in New York. She is currently the Associate Director of the Cerebrovascular Center, co-director of the Pediatric Cerebrovascular Disorders Program, and co-director of the Neuroendovascular Surgery Fellowship Program. Congratulations. We know that she's now serving as the president-elect of the Society of Neurointerventional Surgery and past board member of the Society of Interventional Neurology. She's authored hundreds of publications, is associate editor of the Stroke Vascular Interventional Neurology Journal, and is actively involved and led many clinical research trials in adult and pediatric endovascular disease. She specializes in endovascular treatment of cerebrovascular disorders, including vein of gain of malformation, brain aneurysms, AVMs, fistulas of the brain and spine, as well as stroke and intracranial carotid stenosis. Today, we are excited for her talk on vein of gain of malformation.
Thank you so much for having me here today. Looking forward. I'm excited to see old friends and looking forward to hearing, interacting today. So, should I go ahead and share my screen?
Yes, please.
Yeah, I just want to say good morning and really welcome. Really appreciate you being here, John. I was having trouble. Zoom decided I needed a new password just as I'm trying to log on, so I was a little bit late getting here. I apologize for that.
Oh, no worries.
Great to have you here with us.
Yeah, great to be here. And do you see the?
Yes, looks beautiful.
Okay.
I'm gonna disappear so we can concentrate on your talk here.
Okay. Yeah. So today I'm going to be talking about endovascular pediatrics and specifically on vein of Galen malformations, which is the most common arteriovenous shunt in babies. And so I'm going to just go ahead and get started. Here we go. These are my disclosures. And so pediatric neurointervention is becoming a specific subspecialty. These diseases are pretty rare, and they're a different subset of diseases than what we typically see for neurovascular disease in adults. It's important to note that kids are not necessarily small adults. The diseases are different, and the treatment is a little more or a little bit nuanced. The tools that we use are very similar or the same. There's not yet been development of very specific PEDS tools, but this is actually changing. The SNIS does have an active pediatric committee, and so there's a group of us around the country and actually the world that has interest in pediatrics and come together to discuss cases and to develop best practices. But the important thing, like adult neurointervention, but even probably a little bit more important is the teamwork, because this involves specialists from, this type of work involves specialists from many different specialties. So we do have, our pediatric, say, specific neuroendovascular surgery specialists. At our institution at Mount Sinai, we have 3 of us that really concentrate on pediatrics, and but we do interact with many different subspecialists in the pediatric hospital here. So the neurosurgery, neurology, neonatal ICU, pediatric ICU, pediatric cardiology is very important for vein of Galen malformations and AV shunts in babies. And then Pete's hemonc gets involved for certain cases. We're doing now retinoblastoma treatments, and some of the treatments for AVMs are evolving to involve specific medications that target molecules, and that's administered by Pete's hemonc. And then we have a large, in pediatric neurovascular intervention, we have a lot of collaboration with ENT and plastic surgery, because we do a lot of vascular work in head and neck malformations. And of course, for our procedure, it's important to have nurses and technologists that are used to dealing with these small patients, and pediatric anesthesiologists are key. So it's a whole different subset of people that we deal with, but somewhat similar to the adult work. So to delve into vein of Galen malformation, so this is a specific type of malformation that develops in utero. It involves the median vein of the prosencephalon, which is the embryonic precursor of the vein of Galen. And it's thought to start in fetal development around 11 weeks or so. And there's many theories on what instigates the formation of this AV shunt, but there's thought that it may be ischemic changes, or specifically related to gene changes or gene mutations at the local level. And this causes connection of choroidal vessels to the median veins of the prosencephalon. And at this stage in development, there's still this embryonic falcine sinus. So this is kind of a lateral view of the head, and the straight sinus is here, and the falcine sinus is still present at that time. So we often see this preserved in the babies. And this is a good article from 1989 talking about the anatomical features. The vein of Galen malformation is divided into two types based on angioarchitecture. So the choroidal type is multiple high flow fistulas, and often a plexiform network that drains into this median vein, which often, as you see here, is dilated and becomes aneurysmal because of the high flow. And often there's this collecting vein anterior to it, and then the drainage out into the brain, into the sinuses. And then the mural type actually refers to single or very few large fistulas directly into this dilated vein. Choroidal type tends to have high flows, so will present with potential heart failure in very young babies. And then the mural type patients often don't develop heart failure, and then can be treated later in infancy. And some anatomical considerations. So the shunt is located in the choroidal fissure. You can kind of see here this median vein, and then these large fistulas plugging into it, and this plexiform network formation. And the feeding arteries are often the choroidal vessels, anterior choroidal, posterior choroidal off of the PCAs, including the medial and lateral posterior choroidals. And then oftentimes the limbic system does connect to it. So anterior cerebral artery, pericallosal branches come back and plug into it. And then, the limbic arcade, there's a connection from the posterior cerebral artery coming from posterior choroidals or the posterior pericallosal that will also feed into it. And often, many times you see perforator vessels coming off of the P1 segment that also go into also supply the malformation. And some examples of these vessels here that's important, to kind of orient ourselves when we're treating the patient. So here is a left vertebral artery injection and the P1 segment here, right P1, and you see a nice medial posterior choroidal coming into this network, supplying a shunt. Lateral posterior choroidal, this is a nice example of it, coming off a little bit more distally, P1, P2, and then swinging laterally and entering. And then can kind of make it out. It's a little bit easier to see on a lateral view, but this is a part of the limbic arcade, a posterior pericallosal that would connect to anterior pericallosal and then also enter the shunt at that anterior point that I was talking about. And then we also have these perforators, these transmesencephalic feeders that run through the brain and then exit into the fissure and supply the malformation there. These vessels would normally be also supplying choroid or the tectum. From the anterior circulation, we have anterior choroidal artery feeders that can anastomose with the posterior choroidals. And you can see a nice example of a pericallosal coming down and swinging forward to enter it. And then sometimes we have these kind of very dysplastic, especially in a very high flow shunt lesion with leptomeningeal collaterals, especially in neonates. And you can see development of cortical branches connecting into that. And lastly, at times, often later on, we see meningeal branches such as superior cerebellar or posterior meningeal. That's not on this image, but from the meningeal vessels, sometimes you can get infusion of onyx or a liquid embolic, and could help to decrease the flow. So, that's really the anatomy of the lesion and what important, consideration of how to the shunts that we need to close. Clinically, we've been diagnosing these malformations more and more in utero. So oftentimes somewhere around 30th week, women will have ultrasound and you see this midline vascular structure, lights up on Doppler. And then this sparks a referral. We get usually in this day and age, a fetal MRI to look at the malformation. You can see the size of the median vein, and that can give you an indication of the flow, and also to look at the brain tissue, because sometimes in utero you can have development of encephalomalacia, such high flow shunts that you develop melting brain syndrome, and that's important to know to prognosticate for the parents on whether the baby will be affected at birth neurologically. So in this case, the brain looks okay, and we can be kind of confident that this is a vein of Galen malformation. In that case, what we do is typically for us, if we diagnose a patient in utero, we have the mom give birth at our center, because the neonates sometimes develop high output cardiac failure, and that can necessitate treatment acutely in the neonatal period. So we'd like to avoid having to transfer a neonate. So when we can, we have them deliver at our center. Sometimes that's not possible, and sometimes the diagnosis happens at birth because of respiratory failure, and then patients need to be transferred. In infancy and childhood, say the patient makes it through the neonatal period without heart failure, or maybe they weren't diagnosed at all. Babies can be diagnosed due to development of hydrocephalus, as shown here, with enlargement of head circumference. And then because of the high flow shunt venous hypertension, you can start develop developmental delays and sometimes calcifications in the brain tissue. So if we diagnose in the neonatal period and we don't treat, we follow for calcifications or development of hydrocephalus with the plan to treat in the upcoming months. So the treatment is standard endovascular embolization has been the treatment of choice for several decades. Really, if you look into the old literature before the 1980s, surgery was not, it was very morbid. Most babies, 90% of babies did not survive. And those that did were significantly affected. Transarterial embolization changed all of that. Transvenous was tried at first with coiling of the torcular, also did not have very good outcomes. Mainly, you can save the baby from heart failure, but the development was often not normal. And then once the catheter is developed that you can go transarterially to close off fistulas, this has really become standard at most high volume centers. Some centers do use coils in combination with liquid embolics. It is technically somewhat challenging, but the goal of treatment is to close the fistula at the site of the shunt, not proximally, and I'll show some examples of that. And this really reduces the shunting, especially in the neonatal period, to get the baby out of heart failure, and then decreases the venous outflow, venous hypertension, and the effects on the brain. And sometimes we see features that may be the baby may be at risk for hemorrhage, such as small aneurysm, things like that. So sometimes we embolize to decrease the risk of hemorrhage. So for treatment in the neonate, it's important to maintain umbilical artery and vein access. We ask the neonatologist to place these lines at birth. And so they can be placed, up to, say, 12 hours, maybe a little bit longer after birth. And so if they can get 2 arterial lines and 1 venous line, that's perfect. It gives us 2 arteries to attempt to get into the aorta. We found that accessing the femoral arteries in the neonatal period, while possible, often leads to thrombosis. And since these patients require multiple treatments, that becomes problematic later. And we really only treat in the neonatal period if there's medically refractory heart failure, because the risk of embolization is highest in newborns. And in this time period, the embolization has to be highly efficient. You really, the babies are often 3-4 kilograms, so you only have a small amount of contrast to work with. So the goal is to go in, close big shunts, and to get out as safely as possible. This is after exchanging the umbilical arterial catheter for a sheath, a 4 French sheath, and that's a 4 French diagnostic catheter going in. We looked at our series of neonates about, this is about 10 years ago. So we had 16 neonates back then over 5 years, and 8 of them required treatment as a neonate. And so it's become a fairly positive prognosis. If you have normal brain on MRI at birth and you require treatment as a neonate, about 2/3 develop normally with closure or near closure of the malformation. In that series, there was of the 8 that were treated, there was 1 death, 1 with a mild hemiparesis, and 1 with severe delays. And I think it may, this probably still holds true to this day about you can have a pretty high chance of good outcome with even with treating these very sick babies at birth. And so The embolization, like I said, in the unit is to decrease the shunt, and we still at our institution use MBCA injection to the side of the fistula. And I'm going to show a case example. This baby was born at 37 weeks, 1 day gestation. APGARs were 9 and 9. And we always do an MRI and an echocardiogram on the first day. Sorry. And so the echocardiogram showed significant reversal of flow in the aortic arch, meaning that with each systole, the blood being pumped out, and diastole, blood being reversed and going up into the head instead of down to the body. And so that we use that echo on day one as a guide, not as a 100% guide, but if there's no reversal of flow, then we know we won't need to do anything in the neonatal period. If there's a lot of reversal of flow, we're kind of ready to do something. The MRI, this is the MRI. The MRI showed a normal brain, and the MRI showed this large aneurysmal vein of Galen, and you can see off of the posterior cerebral artery these tortuous dilated fistulas that are plugging into that vein, or into a channel that's actually anterior to that vein. They're all kind of coming into this section right here. So the baby was doing well on day one. Day two started to develop increased work of breathing, unable to feed, and then progressed to respiratory failure requiring CPAP and then intubation. And so this is a decision that we make with the cardiologist and the neonatologist, that if this does not appear to be medically manageable. The baby needs to be able to feed and not be on respiratory support to leave the hospital. If that doesn't look possible, then we go for treatment. And so this is just an X-ray shot on the left of us exchanging the umbilical arterial line for a sheath, and then a left vertebral artery injection, the AP view showing these dilated fistulas going in, and you can see on the lateral view, they're all, not all of them, but it looks like it. Oftentimes there's so many fistulas in the neonate that it's hard to know exactly what's going where, but we do see this large shunt coming in right here. There's probably another one coming up here. And so our goal in this time is to try to close the biggest one, get rid of flow, and get the baby out of heart failure. Here's a microcatheter coming up the left vertebral artery into that, go back for a second, into this right posterior medial choroidal vessel. And you can see the flow is massive going through this fistula, and we're very close to the fistula point coming out of the vein of Galen. And so what I was saying, technically, it's very hard to get coils to sit here. So, coiling proximally is not very helpful, because this channel here is actually getting feeders from multiple other vessels. So those will just enlarge with time. So you need to try to close the shunt at the shunting site. And so this is our 90% NBCA. And we would have liked more of it to probably sit here, but you're in with 90%, it polymerizes sometimes quickly. And you could see that in the beginning of the injection, a little bit of it breaks off. It's such high flow and goes down. It may lodge here, it may go into the lungs. If it's a little bit, it's usually without consequence. And that seals off that big fistula. In the first embolization session for this baby, we closed 2 big fistulas. You could see the glue, shadow of the glue sitting here. This is the beginning and this is at the end, and there's some decrease of flow. And it's difficult to judge how much is enough. In this case, we stopped at this point, and the baby was doing a little better. However, perhaps because of dilation of these other fistulas coming to that point, he ended up requiring 2 more embolizations, which for the sake of time, I'm not going to go through, but we ended up, this is a right internal carotid artery injection, AP view and lateral view. And you can see here is a good example. Here's a pericallosal vessel coming over, down, and then there's some glue in there, and you can see some glue has actually gotten across the fistula site. So there's some in the fistula, some in the vein, which is what we like to do. And so at this point, there was significant decrease of flow. And so there's often a tipping point as you close fistulas. If there's so many as you see here, you may close 1 or 2 and have minimal effect on the flow. And then once you get to a tipping point, then the flow starts to come down. He was able to get off of respiratory support. So this is the glue cast of what we had done over those 3 procedures over about I think day 3, day 5, and something like day 8 of life. And then this baby is actually currently in treatment. He's doing very well. He's developmentally normal. He's come back for treatment at 6 months and is doing well. And that vein is actually shrunk down significantly. And just to show an example of another type of NBCA injection, this is an infant that had prior treatment, and you can kind of see that the coils, there were coils placed, and the coils are proximal to the fistulas. So in doing that, then these fistulas that plug in distal to the coils will grow larger, and eventually the malformation will be the same. So it can be a temporizing measure to get the baby out of heart failure, but in actuality, when you do that, it eventually the other remaining fistulas get larger, and sometimes if you close too many of them like that, then you block off all access to the malformation to be able to close the actual shunt located right here. But this baby came for further treatment with us in here, and in this case we used a detachable tip microcatheter. So for those of you who use NBCA, you know it's a form of, or who don't use NBCA, know it's a form of medical form of crazy glue. So it can glue the catheter in, this microcatheter. And so if you use a microcatheter, that you can actually glue the tip in, and then it detaches. This point from here to here can detach and remain. Then that can sometimes be helpful when you're using very high concentration NBCA. This is the glue injection into this choroidal feeder here. You can see that glue has streamed across the shunting site and it's entered the vein, which is okay. And then it's coming back along the microcatheter to seal off that fistula. And at that point, when you're using a detachable tip, if you're using a regular microcatheter, you have to remove it very quickly so it doesn't get glued in. If you're using a detachable tip, you can stop and then gently retract it, and this tip will remain. So in this baby, in these kids, what we have been doing for many years is staged transarterial embolization. So you want to decrease the shunt, have the vein shrink slowly. Sometimes you see development of these collaterals as that's happening. As you close more and more of these fistulas, the vein shrinks, and then eventually in this progression, you can see eventually, most of the time you can have complete closure of the malformation and preservation of the brain. I wanted to mention in the remaining time some new developments of what technical developments and what we've been doing to treat the patients in the last few years. And this is because sometimes, as you can see in that patient and then in this patient, sometimes you end up with this very extensive vascular network that looks like an arteriovenous malformation, but it really isn't a true malformation. It's really development of angiogenesis or growth of vessels that were already there. And we publish that when we see this in babies, we call this a fine vascular network formation. That the patients are usually older at the age of presentation, and this really affects the treatment that we need. With these patients, more treatments to close off these vessels. And these patients do have more neurodeficits and more hydrocephalus, and their treatment actually has more complication risk because of going through these small vessels. And so there's two things that we've developed recently. One is using a balloon microcatheter, which allows us to arrest flow in the feeding vessel and then penetrate something like MBCA, but a little bit different, onyx, which is not a fast polymerizing glue, but a slowly polymerizing agent that you can push through the network to seal it. And then we've also been using a transvenous approach, different than the old transvenous approach of just coiling off the big bubble, but something called the Chapeau pressure cooker approach, which is to get liquid embolic from the vein backwards into the arterial network. And I'm going to show some examples of those. Both of those techniques we've recently published on. So the mini balloon microcatheter, we published, it facilitates penetration of these networks and curative embolization. We used at the time of this publication 17 mini catheters in 12 patients at the median age of 2. All of them had this network. That's why we were using it. And we used mainly through posterior choroidal vessels that are not serving eloquent brain. In this series, one patient had difficulty with retrieval of the balloon catheter getting stuck, and we had to do some manipulations to get it out. And then another patient had intraventricular hemorrhage, probably because of extensive penetration of the network. I'm going to show that case in detail. And eventually, because of the IVH, needed a third ventriculostomy, but then recovered. And then with the transvenous approach, we've had now a little bit over this, a few more patients treated, but in this article, we had 15 patients treated with transvenous as the final stage for cure. The median age was 3.6 after they'd had staged transarterial treatments. And in that series, 2 patients had IVH and both recovered after. And the case example I'm going to show, we use both techniques. So, this kind of vascular network sometimes can develop after coils are placed. So in the beginning, it may be big fistulas, but when you put up coils and don't get distal, then the kids can develop this extensive network to get through to get flow to the fistula point. And in this case, we can put a mini balloon, and you can kind of see the shadow of the balloon inflated here, and inject, and this makes it so that the onyx cannot reflux into the normal vessel. And in this case, you can penetrate through this network and get embolic material right here into the vein, and close off, begin to close off the shunts. So that's, this is one example of the mini scepter. And then I'm going to show, most of our cases involve little amounts of liquid of onyx, little liquid embolic to close off the network and the shunts. In this case, I'm going to go into more detail. And in this case, we ended up putting a fair amount of the onyx, but this was a good illustrative case. It's a 12-month boy who presented with basically increasing head circumference. He actually is from Mexico, and the vein of Galen was identified on an MRI and MRA during workup for actually increasing head circumference and irritability. And an exam, he was macrocephalic, and he had motor and language delay, otherwise playful and interactive. His echocardiogram showed chronic volume overload with dilated chambers and dilated superior vena cava, but not heart failure, not symptomatic heart failure, and he did not have any other congenital heart disease. So given this, we had some arrangements to do, and the infant was scheduled for angiography and the beginning of embolization. I'm going to show, so this baby presented a little later at 12 months, and he had this extensive vascular network that looks almost like an AVM, but I don't think so. And when he came for angiogram, you can see here this extensive network that makes embolization with NBCA difficult. There are still some large fistulas that you can access with microcatheters, but most of it was this very extensive network. So, and this is the left common carotid artery injection, showing that there's less network perhaps on the left side. And this is the vertebral artery injection. It's showing very extensive network coming off of choroidal vessels and transmesencephalic vessels. And you can see even collateralization over here coming forward from normal vessels, cortical vessels. So his treatment course, the first time we brought him in, we did the angiogram, and then we always combine angiogram with treatment in these kids. So at 15 months, it took him a few months to arrange because he was coming from out of country. And finally, he had 5 transarterial treatments and a final transvenous for cure. But just to go through how that works, in the first embolization, we had small magic, they're called magic microcatheters, 1.2 French, and went into left posterior choroidal feeders and used NBCA. Here's some examples of the NBCA injections. You can see where the microcatheter is going up and the glue there, and another deposition of glue. This was after the first embolization, and you could see it's making a little dent. As Dr. Berenstein would say, this is like fishing in the ocean. So we thought we had to do something a little bit more aggressive, and so the patient went home and was really not developing, not walking, not saying words. So we decided to be more aggressive, and this was one of our first cases with the dual lumen balloon microcatheter. And when he came back, you could see maybe there was some decrease in that network that we had embolized, yes, but there was still extensive network remaining. And so, and you can see also there's this large pericallosal feeder that gives you access to the malformation. And so we decided to focus on that. And this is the mini balloon navigated into that vessel and just posteriorly to the vein of Galen malformation. And then in this case, we were very aggressive, injecting about 5 milliliters of onyx into the malformation, filling that network extensively, and being careful. This is the in this type of embolization, you have to kind of have in your head where the perforators are, and if you see onyx reflux into those perforators, then you know you have to stop injecting. And that's what we did. We ended up with an extensive embolization. You could see the onyx, you could see the perforators here, and the onyx kind of reaching back just to that point. And then after that, this was the patient that the next day he began to be irritable and got a little drowsy over the day. And we got a CAT scan that showed intraventricular hemorrhage, probably unclear why, but that's an extensive amount. That's probably the most onyx we've injected there. And he became more drowsy, so our pediatric neurosurgeon did an endoscopic third ventriculostomy, which worked and perked him up. And then we did an angiogram to see if we could identify what had bled, but it looked the same. So he recovered. He was discharged home about a week after the procedure, and he actually experienced no lasting neurological consequences of this. In fact, he improved his baseline, and then over the next few months, he began to progress with his developmental milestones. And so just to summarize, for the next few embolizations, embolization number 3, we did MBCA with small microcatheters into small vessels, and then on 3 and 4, and then on the 5th one, we did another miniature mini balloon and put some more onyx in a small right posterior choroidal vessel. And I'll show here, you know, it was this vessel down here, which is a little bit larger, big enough to fit the balloon. And then, you know, this is the embolization number 3, basically when he came in 2 months later, and you could see that, you know, each time we're shrinking, you know, we close off this vessel, it's not there, and now we're attacking these vessels, they're not there, and then we're attacking more of these vessels. In the meantime, the flow is decreasing and the vein is shrinking. And then at this point, we decided he was ready for cure. And so the 6th and final embolization was a transvenous approach. This is what the vein looked like at the time. So you need the vein to be fairly small to do this approach, and you need to really be able to visualize the remaining feeders, and you can see them here and here. And this is a direct jugular puncture with a 8 French sheath, navigation of a guiding catheter into the falcine sinus here. We use an inner catheter, and then the outer catheter is advanced and placed into the falcine sinus. So you have a nice guide to place your microcatheters. And then, oops, this came out. So this is kind of an oblique view showing the falcine sinus coming down, and this is a lateral view showing the falcine sinus. And in this case, what was interesting is that because of the MBCA, the vein had bifurcated, so there were kind of 2 channels of veins here. So we placed detachable microcatheters. So the idea is to penetrate liquid embolic onyx retrograde into these feeders that you can see on the left panel this feeders and these feeders that are really the remaining feeders, and then close the vein. So you're in this approach, the transvenous approach has different risks, because the first thing you do when you do it is close the vein. So there's a risk of hemorrhage when you do this. And so you can see the microcatheter in place for onyx. It's detachable because we're going to be putting coils here, injecting onyx, and then we're going to detach the microcatheter here. You could see on the right panel the coils in place, and then injection of the liquid embolic over here, and you can then see the liquid embolic going retrograde and filling those feeders here and here. And then at some point we often use NBCA and this kind of shadow here to completely seal off the retrograde pathway of any liquid embolic if we see that it's coming back through the coils. And so in that way, you can control the situation and close the vein and attempt to close off as much of the feeders or all of the feeders, really. And this was the final cast of the embolic material. And then here is the angiogram at the end of the procedure. So the malformation's gone, the venous outflow of the brain is looking more normal and draining anterograde down the sinuses. And he recently came back for a control angiogram. We see that these patients sometimes develop dural malformations. So we always do a delayed angiogram to make sure that's not the case. And in his situation, everything looked perfectly normal. And he was, he did well after that procedure. Angiogram shows persistent occlusion, and he actually started walking, babbling. That's him and his family with permission. So, and then when he came for follow-up, we did MRI, and you could see that the hydrocephalus is still there. You can see the malformation has shrunk, the vein has shrunk, those dilated vessels, there's from that initial aggressive onyx, we see that kind of sitting there. And what's interesting though is that the vessels, if you recall in the beginning, his initial MRI, there were vessels in the right thalamus, and those have all regressed. So kind of in confirmation that wasn't really a thalamic AVM, those were all in response to the AV shunt, so dilated collaterals to the shunt. And this is his recent angiogram. So this is a case illustrating all of our newer techniques, and nowadays we're a little bit more aggressive to go for a cure in these malformations. So in conclusion, the vein of Galen malformation, it's a challenging disease. It's requires stage treatments. It's technically challenging, and no two cases are identical, really. Those they're all different, but there's a general rubric for thinking and treating these patients. And it's building in over 3 decades of experience of all of our senior neurointerventionalists who've really walked this treatment and developed these treatments. And nowadays, really good outcomes can be achieved much of the time. And in our center, at least, our advances in the last 5 years have pushed us to achieve cure most of the time. Now, sometimes if we have a little bit left, and the patient's doing perfectly normal, we don't push for cure. But in a case like this, we will decide to go for cure. And so I'd like to thank our team, Dr. Berenstein, who's been, on the forefront of treating this for many decades, and Dr. Shigematsu, who is part of our pediatric team, and Dr. Nimi, who was with us for many years in treating these patients. I'd also like to thank our team. We do have pediatric nurse practitioner and physician assistant who really assist and help with the families. So I'd like to thank you, and happy to take any questions.
Again, we thank you for that excellent review, as well as talk us with respective to endovascular management of this particular disease. I see our panelists, Dr. McDougall, Dr. Monteith is available as well, and Dr. Monteith has his hands raised.
Hi, Johanna. Thanks. That was a wonderful talk. Really enjoyed it. I was just curious, obviously NBCA kind of dominated the transarterial embolization. What percentage of cases now would you be using NBCA upfront versus Onyx with septors and detachable balloons and so forth? And a little bit off topic, but did you ever get a chance to use Onyx HD 400 before it got taken off the market?
Yeah, so right now, almost all of them, if we start at the beginning, we use NBCA at the beginning, because it's especially in those very high flow shunts. There are some centers that will coil and then put the Onyx
into it.
Yeah. It's more like we have so much experience with it. It's quicker for us to go up with a non-coiling catheter, a Magic. It's like softer, it's flow directed, it'll go up there. And with high concentration NBCA, and actually we use systemic hypotension. I didn't mention that. Within the angio suite, we have the anesthesiologist lower the pressure. We're comfortable injecting into the high flow fistulas, and I feel more comfortable that the NBCA is adhesive. So it's going to stick to the wall. Even if it flies a little bit in the vein, it usually catches and sticks there. Whereas Onyx, if it's not adhesive, it's cohesive, but it could fly away. So usually with big fistulas, we start with MBCA, and then only when we're remaining with this network, then we start doing Onyx. And then the HD 400, we used it. That was many years ago, but not for aneurysms. It was approved, or I guess it was approved for aneurysms in the US, but then it got taken off. But yeah, I used it maybe for 1 or 2 aneurysms and then stopped.
One question from the chat is discuss maybe your algorithm with respect to your staged embolizations in terms of spacing them.
Yeah, it's kind of I guess there's a gut feeling. We usually go around every 3 months or so if everything is going smoothly. And sometimes that's probably every 3-4 months, something like that, because we want to try to, if we're going to achieve complete cure, we'd like it not to be super prolonged process for the patient and family. But sometimes we've had a few patients that when they develop this network, they start getting hemiparesis, they start having developmental delays, and then so sometimes we get more aggressive and have them come more frequently until we can achieve cure. We don't. It's a balance between doing too much and too little, and we err on the side of doing too little, because if you do too much and the whole vein thromboses, then that can be an issue. When it's a very large vein, it propagates to the torcula, and then especially in the babies, then you can have issues, hemorrhages, things like that.
I'm going to jump in. I loved your presentation, Johanna. It's so understated and calm. My palms are sweating the whole time that you're talking about this, because I just don't think that people who haven't treated these cases can really appreciate the level of boldness and the level of judgment that's required to do the kind of work that you're doing. It's pretty spectacular. And you mentioned, everything, and of course more than I know about. I haven't dealt with the vein of Galen's for a long time now, since I left Phoenix, but some of the things I really want to sort of highlight that you mentioned are the efficiency, how in the newborns in particular who are in failure, just how efficient you have to be with your imaging, and how much you have to have planned ahead in terms of the MRA and knowing where you're going, and the umbilical catheter, preserving that, the artery, and really getting that distal penetration with the NBCA and the team. I mean, I remember really struggling with the team, with cardiologists who really didn't understand well enough what they were getting into, and you'd have such a small window of the baby. The failure was not severe enough that you could do the procedure, but if you waited 24 hours, you were out of the window, and it was lost. So really just a spectacular presentation, and a spectacular progress over the years that your team has accomplished. And it really, I despair a little bit when I think of children being born in failure in areas where they just don't have access to that kind of team, and despair both for the baby and for the practitioner who's in over their heads with a baby in failure. So it's really a tough thing, and really does need to be regionalized. A technical question though, on the last case you showed, and the development of transvenous, that's really fun to see that sort of still be there as an option, when it was it was really unclear a long time ago whether transvenous could be used or not, and to find a niche for that, and a really successful one. When I was looking at that case, I'm trying to think, how are you doing that? You really only have the PA view. You've got such a chunk of onyx in there, and the lateral view looked like it was obscuring the onyx you're injecting. How do you manage that?
Yeah, it's really for these cases, we usually have 3 of us there, and we're all looking, and we do a 3D. We don't usually do 3Ds in little people, but we do a 3D to try to see where the feeders are connecting, and then it's just it's like keeping that in your head. We have it set up so we have images up, on the screen, like a few different images from different vessels, so that when you put such a big onyx cast, then it's hard to see, but everything in the middle of usually the feeders, you don't want to get things too far off the edge of the onyx cast. So but that's why we really reserve it from when you think you can see
Last stage
you need to see. Yeah, the last stage. And we have done some where it's a little bit more, and it's I think we're getting a little bit more comfortable, but it's last stage. And then you have to really, when you set up your AP and lateral or whatever view you're using for the onyx injection, in your head you have to know where the onyx should be going and where it shouldn't be going. And so if you see it go towards normal brain, you have to pause, and then but it is nerve-wracking in that once you start, it has to go to where you want it to go, because you can't leave that place without onyx, because then it can potentially bleed. And so oftentimes we put a microcatheter in the remaining feeder, so that we can actually do control runs of the microcatheter during the onyx injection to make sure that we're getting what we think we need to get closed.
Yeah, beautiful work. And the other thing is just how much judgment is required in these, and I think the learning curve is so huge for knowing when to quit, knowing what you can do safely, knowing what you can get away with. In these cases, there's just no margin for error.
Yeah, I think it's tough. It's tough to not, because we do, I was saying we do pediatric cases, and we can only do one a day, so it's not the most efficient practice, but like, you know, Wednesdays and Thursdays. So we do probably 2 kids every other week or every, so it's and it's, if you don't do it for a while, it is something that requires continuous practice in it, because then you kind of come back and you know, be a little disoriented in what you're doing. But it does require judgment, and we're, you know, still we misjudge things at times, you know. Yeah, so it's a bit, yeah, there's, I didn't mention when you're injecting the MPCA, there's hypotension for the kid and tachycardia for you, usually. Yeah.
I do see a question in the chat. Sorry to jump in there, Cliff, but about rapid ventricular pacing. Have you ever used that?
We haven't. I've spoken to a couple centers that have done it, and yeah, I think we just have, especially in the neonates, well, our anesthesiologist would definitely not allow us in the heart failure baby to do that, but maybe in some of the infants, you can kind of arrest flow and then be a little bit more relaxed in your MBCA injection, but we just ask for hypotension.
Great. Any other questions from anybody, Cliff?
Not from the chat. One question I had was, have you had or started to have any experience doing fetal management? I know some centers are starting to do in utero management of these to try to catch it before some of the post-circulatory issues of the neonatal period. Yeah,
we haven't. I know, yeah, Dr. Urbach, Darren, he did one case and he's been developing that. It's kind of a niche. You have to be in a place where they can do fetal surgeries, and yeah, we haven't yet explored it. I'm not sure we have to see, you know, he's running a trial to see what the outcomes are. The idea with that is to put coils into torcula to slow down the flow so that they don't have to be treated neonatally, and then they can be treated later on. You know, it's to be seen whether the important thing is the clinical outcomes at the end, how they're going to be.
And in respect versus surveillance monitoring imaging, like non-invasive, are there any things that you kind of sometimes recommend to the radiologist or obtaining imaging, you know, to high quality resolution?
Well, we have, when they're on day one, we do MRA, MRV, MRI, but for surveillance after, like, if they don't need treatment in the neonatal period, we actually more often than not do CAT scans, because it doesn't require anesthesia, to look at the ventricles and to look for calcifications, because that'll push us to treat sooner. If not, we usually treat at about 6 to 8 months. Yeah. If they're going to go to sleep for some other reason, we do an MRI, but and try to avoid anesthesia.
Thanks.
Great. Well, beautiful presentation, wonderful work. Really grateful for you being here with us this morning. And sorry I was a little late jumping on. And congratulations on your election for FNIS. That's great. Thanks again.
Thank you so much for having me. Nice to see you.
Thanks, Johanna.
All right. Take care. Bye.